Welcome to Med Madness, your go-to podcast for mastering medical knowledge for the USMLE Step 2. Today, we dive into an essential topic, cardiovascular drugs, Part 1. Understanding these drugs is critical for managing various cardiovascular conditions you'll encounter in both exams and clinical practice. In this episode, we'll cover 4 key sections. First, management of hypertrophic cardiomyopathy. Next, medication-induced bronchoconstriction. Then, beta-blocker toxicity. And finally, peripheral edema with calcium channel blockers. By the end of this episode, you'll have a solid understanding of how to manage these conditions effectively. Let's start with a case study. A 32-year-old woman presents with exertional dyspnea and chest pain. She has a family history of sudden cardiac death. Physical examination reveals a systolic murmur at the left sternal border. ECG shows left ventricular hypertrophy. The diagnosis is hypertrophic cardiomyopathy, or HCM. For asymptomatic patients, routine clinical monitoring is recommended to keep an eye on disease progression. Symptomatic patients experiencing dyspnea or angina should receive first-line treatment involving beta blockers or non-dihydropyridine calcium channel blockers to reduce symptoms by decreasing heart rate and myocardial contractility. Reducing the heart rate is important because it increases the left ventricular filling time and decreases myocardial oxygen consumption, which helps to relieve symptoms and improve cardiac function. Patients with a high risk for sudden cardiac death, indicated by prior syncope or family history, may require ICD placement. Atrial fibrillation management includes rate or rhythm control and anticoagulation to prevent thromboembolic events. Significant left ventricular outflow tract obstruction can be addressed with septal ablation or surgical myectomy to relieve obstruction. For non-obstructive refractory symptoms, consider cardiac transplantation. Next, let's discuss medication-induced bronchoconstriction. Here's a case study. A 55-year-old man with a history of asthma presents with worsening shortness of breath after starting propranolol for hypertension. He reports wheezing and a tight feeling in his chest. The diagnosis is medication-induced bronchoconstriction. For management, note that non-selective beta blockers, like propranolol, can trigger bronchoconstriction by blocking beta-2 receptors in the lungs. Cardioselective beta blockers, like metoprolol, are safer for asthmatic patients but can still cause bronchoconstriction at high doses. ACE inhibitors can also cause a dry cough due to increased bradykinin levels, which may exacerbate asthma symptoms. Now let's move on to beta-blocker toxicity. Consider this case. A 60-year-old man accidentally takes an overdose of propranolol. He presents with bradycardia, hypertension, and confusion. He also has wheezing and low blood sugar levels. The diagnosis is beta-blocker toxicity. In beta-blocker toxicity, the mechanism involves decreased intracellular camp due to adrenergic blockade. The clinical presentation includes cardiac suppression with bradycardia, hypertension, and confusion from beta-1 blockade and bronchospasm, hypoglycemia, confusion, and seizures from beta-2 blockade. Hypoglycemia occurs because beta-2 receptor blockade impairs gluconeogenesis and glycogenolysis, processes vital for maintaining blood glucose levels, especially during fasting or stress. Diagnosis is supported by ECG findings showing sinus node dysfunction and atrioventricular block. Treatment includes intravenous fluids for hypertension, atropine for bradycardia, glucagon to increase intracellular camp and improve heart rate and contractility, and calcium gluconate to increase blood pressure. Peripheral edema is a common side effect of dihydropyridine calcium channel blockers, such as amlodipine. CCBs cause preferential dilation of arterioles over venules, increasing capillary hydrostatic pressure and leading to fluid extravasation into the interstitium. Adding ACE inhibitors or angiotensin II receptor blockers can counteract this by causing venodilation, reducing capillary hydrostatic pressure. Next, let's discuss a case study. A 70-year-old woman taking amlodipine for hypertension develops noticeable swelling in her ankles and lower legs. She reports feeling otherwise well, but is concerned about the swelling. The diagnosis is peripheral edema induced by calcium channel blockers. Understanding the mechanisms, clinical presentations, and management strategies for these cardiovascular drugs is essential for effective patient care and success in your USMLE Step 2 exam. Remember to engage with pre- and post-podcast quizzes and use Anki flashcards to reinforce your learning. Stay curious, stay motivated, and keep learning.